We've got another Journal Club episode for you today. We're going to be diving into a recently approved treatment option for people living with chronic hives. We're breaking down the REMIX trial, a study that looked at Remibrutinib, a new pill that works differently from antihistamines. I'm Courtney, bringing you the patient perspective. And joining me, as always, is the brilliant Dr. Payal Gupta, a board-certified allergist and immunologist, and our favorite third co-host, Dr. Michael Blaze. This podcast is made in partnership with the Allergy and Asthma Network. We want to thank Novartis for sponsoring today's episode. While they support the show, all opinions are our own and sponsorship doesn't influence our content or editorial decisions. Any mentions of brands is for informational purposes only and not an endorsement. Now, let's get to it. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. Welcome back to another Journal Club episode. We're going to be reviewing Remibrutinib in chronic spontaneous urticaria. This was published in the New England Journal of Medicine in March 2025. This paper covers two big phase 3 trials called REMIX 1 and REMIX 2. So before we jump into the actual paper, I think there are some terms we're going to have to unpack so we understand what we're talking about. So Dr. G, can we start with the basics? What exactly is chronic spontaneous urticaria?
Yeah, so we've done a lot of episodes that go into CSU or chronic spontaneous urticaria. We will link those episodes to the show notes, but for our listeners today who might not have already listened to those, I'll do a quick summary of what we mean by chronic spontaneous urticaria. This condition is basically what it sounds like. Chronic means that it's been present for a while, and in this context, it's been present for at least 6 weeks. Spontaneous means that it happens randomly and without any trigger. And then urticaria is the medical term for hives. So people with CSU will have itchy skin and hives, which are those raised red welts that can appear anywhere on the body, and can also have angioedema, which means a deeper swelling. And sometimes people have both of these. They'll have the hives and the angioedema, or they can have just one or the other. What makes CSU so frustrating for patients is that there's no obvious cause. So it's not like a food allergy where you eat peanuts and then you react. The hives just kind of show up, sometimes in the morning, sometimes at night, sometimes after stress, or sometimes for no reason at all. And this can go on for months or even years for some people. And I think what's really important for our listeners to know is despite how much this disease affects quality of life, and we're talking about sleep disturbance, difficulty concentrating, embarrassment because of the hives and the way that they look, or anxiety, the diagnosis can often take 2 to 3 years for people to be accurately diagnosed. Even once patients are diagnosed, many of those patients don't get adequate treatment. And so there's a real gap between how much people are suffering and how well we're managing this condition. And so treatment is a big topic in this area. And for a long time, the first line treatment, which means the medications that we use first for this condition, are what we call second generation H1 antihistamines. So we're talking about medications like cetirizine, fexofenadine, levocetirizine, or loratadine. These are all the generic names for all the antihistamines that people might be familiar with. But here's the thing, more than half of patients don't get relief from antihistamines at the standard dose. And even when doctors increase the dose up to 4 times higher, which we do in this condition, up to 75% of patients still have symptoms. So there's a huge, again, unmet need for better treatment options. And that's why this study really matters. It's looking at an option for these patients who have tried antihistamines and are still struggling.
Thank you, Dr. G. That was an awesome recap. And like you said, we have a lot of episodes about CSU or chronic spontaneous urticaria, and we have those episode links in the show notes, so you can go and listen to those if you want a deeper dive in terms of what CSU is. Before we get into the paper, there is one other thing that I want to mention. This isn't our first BTK inhibitor episode, so I have a little bit of understanding or memory of those episodes. And we have talked about how BTK inhibitors have been used in other diseases, and they've been used to treat other diseases, so they're not totally new. Dr. Blaze, can you tell us a little bit about that?
As you mentioned, BTK inhibitors aren't new. In fact, we've been using them for years now as very effective cancer treatments. But I think it's very important here to point out that remibrutinib is a very highly selective BTK inhibitor. And so what that means that it truly just targets or almost completely targets BTK specifically and not a lot of other things. And that, as we'll talk about, is extremely important as far as the safety of the product.
Thank you. I feel like we're ready to dive into this paper. So, Dr. Blaze, can you tell us what this paper was looking at?
This paper is a phase 3 study looking at, again, remibrutinib and the treatment of adult patients with chronic spontaneous urticaria.
Can you tell us what the objective of the study was? And when I say objective, basically is what was the study looking at? What were they trying to figure out?
So the objective, again, what they were trying to figure out here is how effective is remibrutinib in the treatment of patients with chronic spontaneous urticaria. In other words, what happens as far as their hives and itching with this treatment compared to placebo.
And so now that we know what the study was looking at, how was this study set up?
So the way they did this study, it was 2 separate trials, and they named these Remix 1 and Remix 2. Now, these trials were designed to be identical, and that's extremely important because you want to run 2 separate trials here, and if they're identical, you hope to get the same results. And then, therefore, it really strengthens the evidence as far as the effectiveness and safety of this product. So these were phase 3 trials, which means, again, it was the final stage of testing before a drug can be approved. Just so everyone knows, this drug is officially approved. It's available now. It's approved by the FDA last year in September of 2025. Now, let's go more into this study, though. This study was multi-center, so patients came from different sites around the world. What was interesting is that there were subjects from all continents in the world except Antarctica, and these were double-blind placebo-controlled trials, meaning that neither the patient nor the doctor knew who was getting the real drug versus placebo, which again, placebo is a dummy drug or a fake drug. Now, the patients were randomly assigned in a 2-to-1 ratio here. So for every 3 patients that were enrolled in the study, 2 got remibrutinib and 1 got placebo. The dose of remibrutinib was 25 milligrams twice a day. So the patients took 1 pill in the morning and 1 pill in the evening. Now, here's something that's important. Everyone in the study stayed on antihistamines. So this wasn't remibrutinib instead of antihistamines, it was remibrutinib on top of antihistamines. So we're testing here whether adding this drug, remibrutinib, could help people who weren't getting enough relief from antihistamines alone. Now, the main part of this study lasted 24 weeks, with the primary endpoint that was measured here was measured at 12 weeks.
Let me see if I understood exactly how this study was set up. So you actually had 2 studies going on at the same time, but they were set up exactly the same thing. So it was 2 exact studies, and the good thing about having 2 exact same studies running at the same time is that if both of these studies have the same results, then you're double covered and you know that there wasn't some weird freak anomaly that it happened the same way in both studies. And in those studies, you had a double-blind placebo-controlled study, which is one of my favorite things, and that's basically that no one knows whether they're getting the actual medication, which is remibrutinib. And remember, remibrutinib is that BTK inhibitor, so they either got the remibrutinib or they got the placebo or dummy pill. So for every 2 patients that got the remibrutinib, 1 patient got the placebo, and that's what Dr. Blaze meant when he said it was a 2-to-1 ratio. And the study ran for 24 weeks, but at 12 weeks is when they looked at the primary endpoint. Dr. Blaze, can you explain to us what an endpoint's
basically what the researchers decided to measure, determine if the treatment worked. So it's the outcome they're looking for. And in this particular study, the primary endpoint, which again was measured at 12 weeks, was the change in something called the UAS7. Now, what is the UAS7? What's it stand for? It's the Urticaria Activity Score over 7 days. So, this UAS7 is basically a way for patients to track how bad their symptoms were over a week. So, every day, the patients recorded two things. They rated how bad their itch was and how many hives that they were having that day. So, each one was scored from 0 to 3. So 0 would be like no itch or no hives. 3 would be severe itching the patient couldn't tolerate. 3 for hives would be like greater than 10 hives. You could get a total here in a day, if you were the worst, up to 6 points a day. So over 7 days, the maximum score would be a 42. So a score of 0 means no symptoms at all. So the patient had no itch or no hives. And again, a score of 42 would be the worst possible symptoms every single day. So for this study, the patients had to have a UAS7 of 16 or higher just to even get in the study. So they had to have significant symptomatology. So we're talking about people, again, that were having moderate to severe disease. So these were not patients that had your occasional mild hives. These patients that were part of the study were really suffering with this condition.
Okay, that was really helpful. So basically, what I understand is that the patients were doing something called the UAS7, and that's a way that they scored how itchy they were every day and how many hives they had every day. And they do that over 7 days, and that's why we have the 7. And the higher the number you have, the worse the score is, meaning you have more hives and you're itchier. And I know that they did it at the beginning of the study, which is what we call baseline. So that was before they started taking the Remibrutinib. Did they do it after the 12 weeks? So how many times did they have to actually score themselves?
In this study, they did the UAS7 twice a day, every day through the 24-week study. So to get a score for the one day, they did a UAS7 every 12 hours. So the two that they did over that 24-hour period were averaged. And then they did that every day for that 7 days for that week. And then they continue to do this again every week throughout the 24-week period of the study. And this is extremely important because this is the best way to track how well the patient is doing in this study. And that is to be able to look at changes that were occurring from baseline in their UAS7 throughout that 24-week period.
Basically, what the patients had to do is they had to take this score, so how itchy they are and how many hives they have, twice a day. And then they took the average of those two reportings during that day. And the average of those two was the score that they had for that day. And they did this every single day for 24 weeks. And that's how they saw whether baseline, which is, remember, before they started taking either the Remibrutinib or the placebo, that's baseline, all the way up until the end of the 24 weeks. And Dr. Blaze, you did mention that they had to have a score of at least 16 to be in this study. Is that correct? Did I remember that?
Exactly. And I'll add a couple of benchmarks that will help make sense of the results. So we use a UAS7 of 6 or lower, and we define that as well controlled disease. And that's the goal for most of our patients. And then we have a UAS7 of 0, and that means complete absence of itch and hives. So when we look at the results, we talk about how many people got down to those levels.
Thank you, Dr. Blaze, for those benchmarks. So just so we can understand, basically 0 means no symptoms. And then the lower the number, the less symptoms you have. So the lower the number, the less hives and itching you're experiencing. So, Dr. G, can we jump into who was in this study?
Yes. So, who is in the study? So, between the two trials, they actually enrolled about 925 patients total, 470 in the Remix 1 trial and 455 in the Remix 2 trial. And to be eligible, patients had to be adults. So, they had to be at least 18 years of age or older, and they had to have CSU for at least 6 months. And they had to still have symptoms despite taking those second generation antihistamines, which is the first line treatment that we use in these patients. So the average age was around 43 to 45 years old for these patients, and about 2/3 were women, which is pretty typical for CSU because we do know that it affects more women than men. And like Dr. Blaze said, they had to have a UAS7 of 16 or higher. And you want to remember a UAS7 of 6 or lower was considered well-controlled disease. So these patients do not fit that criteria, right? So they have a higher score, which means worse disease. So what we actually got though with the patients was that about 60% of patients had severe disease, meaning their UAS7 was actually 28 or higher. And the average baseline for the UAS7 for the patients was around 30. So this was a group of patients who were really having a lot of symptoms with their disease. They were very uncontrolled. And one other important detail is that about 30% of patients had previously tried omalizumab, which is also called Xolair. It's an anti-IgE biologic medication, which is another treatment that we've talked a lot about with our CSU episode. So we'll link to that. But essentially, it's a medication that we use for patients that are not responding to that first line treatment, which is the antihistamines. So it's important to know just that those patients were also in that study. So again, patients that were not responding to antihistamines.
Okay. If you guys don't mind, I'd love to see if I can recap all of that and see how much I retained. So basically, we've got Remix 1 and Remix 2, and those are two studies that are exactly the same, right? So they're running two studies to see if they're going to get the same results for both studies. And you've got about 925 patients in total in these two studies. And the patients that were enrolled were still taking antihistamines throughout the whole study. And then you had 2 out of every 3 patients getting the Remibrutinib and 1 out of every 3 patients getting the placebo. So you had 2 times as many people getting Remibrutinib than the placebo. And throughout this whole study, they were filling out something called the UAS7 score to see how much their hives and their itching have changed and whether the medication is changing something, right? And the one other thing when we're talking about the UAS7 is that these patients had to have a 16 or higher. And remember, 0 means no symptoms. And the higher the number, the worse your symptoms are. And they had to have a 16 or higher. And what Dr. G said is that the average score of these patients was 30. So they were really itchy and really hivey people. The one thing, and this is where I'm always like, man, is that there's more women than men who tend to have CSU. So there was a higher proportion of women in this study because that's just generally the disease. And then the last thing that Dr. G mentioned was that a third of these patients in the study had tried the biologic called omalizumab, or also Xolair. And the one thing to note is that these patients were taking antihistamines throughout this study, but they were no longer taking the omalizumab, right? So these patients had tried it, but they're no longer on it. So with that, the big question is, what did they find after 12 weeks?
So let's talk about then what they found. And the bottom line is that Remibrutinib did work and it worked well. At 12 weeks, which again was the primary endpoint, the patients that were on Remibrutinib had a significantly greater drop in their UAS7 scores compared to placebo. And in Remix 1, the Remi group dropped by about 20 points, while the placebo group dropped by about 14 points. And in Remix 2, it was similar, a 19-point drop with Remibrutinib versus a 12-point drop with placebo. And very importantly, these differences were statistically significant in both of these trials. And when you see, again, the same results in two separate trials, this really tells us that the results are real.
Dr. Blaze, if you don't mind, I feel like what you said was the placebo group, which is the group that did not get the Remibrutinib, also improved by numbers that sound quite high to me. So why would that happen if they weren't getting the real drug?
And that's a really important question. And we see this a lot in clinical trials. Now, for this study, remember, everyone in the study was still taking their antihistamines. Now, they also were allowed in this study to take extra antihistamines as rescue medication if they had a flare. So the placebo group wasn't getting nothing. They were getting standard therapy and even increased it or could increase it during the study. There's another reason here that sometimes we see in these studies, and that's called the placebo effect, where people sometimes feel better just from being in a study and from being closely monitored. And the other thing we have to remember about chronic spontaneous urticaria, it naturally waxes and wanes over the time. That's why we use that term spontaneous. But the key here to remember is that, in fact, remibrutinib did significantly perform better than placebo on top of all of that. So the improvement wasn't just from antihistamines or being in the study. The drug really did make a real difference in these patients.
The placebo effect, I feel like that's a term some people like to use and they don't really know exactly what's going on. So thank you for explaining what the placebo effect is, because it's really interesting that like just being in this study can make people feel better. So thank you for clarifying that, because I was a little bit thrown off by those numbers being so high. So you said that the medication definitely made a bigger difference. So it was actually working to help the patients feel better.
Exactly. And here's where it gets really, I think, meaningful for our patients. They also looked at how many people reached those targets that Dr. G and I mentioned earlier. So at week 12, about 50% of patients on remibrutinib had well controlled disease. So again, that was that UAS7 of 6 or lower. And compare that to only 20 to 25% of the patients that were in the placebo group. And for complete symptom control. So again, that would be that UAS7 of 0, meaning no itch, no hives at all. We saw that in about 30% of patients on remibrutinib, compared to only about 7 to 10% on placebo.
It's exciting to see that these people who were really suffering started to feel better. And with that, how fast did they start to feel better? When did they notice symptom improvement?
I think this is really an exciting finding that was found in this study, that remibrutinib worked fast. They saw separation from placebo as early as week 1. And by week 2, about a third of the patients on remibrutinib already had well controlled disease, compared to only about 3 to 6% on placebo. So patients weren't waiting months to feel better. Many patients noticed a difference in those first couple of weeks.
That is so exciting for patients to see a difference happen like that. I think that must have been like one of the best moments for them to realize how quickly it's working. Because I know, as someone who's had that experience where you're like, oh my gosh, it's working already. Holy cow. So it's really like, as a patient who's had that experience before, it's very powerful and it's very exciting.
Absolutely. And the good news is that the improvement held up. Again, they followed these patients out to 24 weeks, and the benefits appeared to be sustained. So the patients kept doing well.
Thank you, Dr. Blaze. That's really good to know that after 24 weeks, they still kept on seeing the benefits of the medication. So, just to clarify, that the results they were looking at, the endpoint was at 12 weeks, but they continued the study for another 12 weeks for a total of 24 weeks, and they monitored the patients for that time period as well.
That's exactly right.
So let me put all of this together just to make sure, again, that I figured it out. And if hopefully I figured it out, then everyone else has figured it out as well. So in both trials, remibrutinib significantly beat placebo, which is the dummy pill, in reducing the symptoms, right? So we looked at the UAS7 score, and that dropped by about 20 points in the group that was taking remibrutinib. So if I was to explain that, it's imagine you had a score of 30, and then after the 12 weeks, your score is 10, right? That's what I mean by it dropped by 20 points. So in the remibrutinib group, it was 20 points. And then in the placebo or the dummy pill group, that was 12 to 14 points. And Dr. Blaze explained why that was still high because of this placebo effect, right? And then if you look at what this means in the real world, about half the patients who are taking the remibrutinib got to well-controlled disease. And about a third of them were completely clear of itching and hives, right? So you imagine you were itchy, and you had tons of hives, and then you got to something that they call well-controlled disease. And that's compared to the placebo group, where only about a quarter of them got to this well-controlled disease and less than 10% got to the 0, right? So they didn't get as clear as the remibrutinib group. And the last thing, which is really exciting, is that it worked fast. So after about a week, people were starting to see a real significance. So now that we know remibrutinib works, Dr. G, what about safety?
Safety is always important for any medication. And the good news is that Remibrutinib had a pretty favorable safety profile. So in both the Remi group and the placebo group, there were about 65% of patients that reported side effects. But remember that when someone is in a study, everything that they experience gets monitored. So over that time period of 24 weeks, they count any kind of cold as something that could have been related to the drug. So during this study in particular, COVID was actually very common. So the most common adverse effects were things like COVID-19, nasopharyngitis, which is basically a common cold, and headaches. And those side effects that were reported at similar rates between the people that were on Remibrutinib or the people that were on placebo. So everyone was having these types of infections during that time, not just the people on the medication, and they weren't getting more of those infections than the people that were on the dummy medication. And then the other thing to note is that most of the side effects that were reported were mild to moderate, meaning that they didn't really interfere with the patient's daily life. Serious adverse events were uncommon. So about 3% with Remibrutinib and 2% with placebo, and none of them were considered actually related to the drug by the investigators. So what does that mean? That means that even though there were serious adverse events that occurred during that 24 weeks, the researchers did not think that those serious events were related to the patient taking the medication. They were events that would have occurred regardless of if they were in the trial or not. And I remember Dr. Blades had used a really good example is that if you get into a car accident and you break your leg during a study, that would be reported in the study, right? So you would have to report that I broke my leg. And so that would also count as one of those things that are reportable. So that's just important to remember that anything that happens during that 24 weeks is recorded.
Thank you, Dr. G. So 65% sounds like a high number, but like what you said, anything that happens to you when you're doing a trial, when you're participating in a trial, has to get reported, even something as random as falling down your stairs and spraining your ankle, is what I understand. So, did anything show up more in the Remibrutinib group?
So there was one thing that we really need to discuss related to safety, and that was petechiae. So this is a medical term for these tiny little red or purple spots on the skin that are caused by small amounts of bleeding under the skin. And in this study, there were about 4% of patients on Remibrutinib that had these petechiae to less than 1% on placebo. Now, it's important to note that they also saw in this study that there was a total of about 9% of patients that had what they called bleeding events that were, as described, mucocutaneous. So, again, under the skin. They described things like contusion, which is a larger area. It was seen in about 13 patients versus 2 in placebo. There was also ecchymoses, which again is a larger bleed under the skin, seen it in 9 patients with Remibrutinib versus 1 with placebo. They even saw a little increased rate in epistaxis, which is nosebleeds. That was seen in 5 patients on Remibrutinib versus 1 with placebo. Now, it's important to point out here is that these generally, especially when we talk about petechiae, which was the most common, were predominantly mild. There were some that were moderate. And very importantly, that these were generally transient. They went away. In fact, only one patient in the study stopped Remibrutinib related to the development of petechiae. And we know that BTK inhibitors do have an effect on platelets. And platelets, again, are those tiny cells in the body that help stop bleeding by forming a blood clot. So a blood clot, as we know, is a thick, sticky clump of blood that forms in the body when there's bleeding and basically stops the bleeding. The thought here is that the BTK inhibitor may be doing this, but I think it's very important here to note that there were no serious bleeding episodes here, that there was no drop in platelet counts in these patients. And so I think it's important patients know that this can occur, but again, it seems to be a very transient, mild problem that happens in a very few percent of the patients with this medication.
What's important is we're reviewing this data after the medication has already been approved. So the FDA did look at these results. They did look at the side effects. They looked at how the medication worked, how well it worked. And then they also always look at the side effects before they actually approve a medication for use in the general population. And so what they decided was that these events were not serious enough to not put the medication out into the market. And of course, now that we're going to be using it in thousands and thousands of patients, we'll truly see, are there particular patients that we need to be more worried about than others? And so that's always something that we get once we start using a medication in real world as opposed to in a study. So it's something that we should always mention to patients so that they're aware and so that they don't freak out if they start getting these small bruises under the skin. And so we want to make sure that they report that back to us and that together, using shared decision making, we decide, do we want to continue the medication or is it time to stop and try a different medication? So these are the important things to always mention when we're deciding which medications to go on. And as Dr. Blaze mentioned, the platelet count, which is where we think the medication may be acting and why these bleeding events may be occurring, the platelet count itself did not get lower while these patients were on the medication. So it's not something that we have to monitor. We don't monitor a patient's platelet count. We just monitor for these bleeding events. And again, it was in a small proportion of patients, and that's why the FDA did decide to approve the medication. And I also want to mention, this is a selective BTK inhibitor. What that means, essentially, when we have more highly selective medications, that means that the medication is doing what we want it to do in the body and not doing other things that we don't want it to do. And so this BTK inhibitor in particular is thought to be more highly selective. And that's why the side effect profile is so favorable as opposed to other BTK inhibitors that we're using in other conditions where the side effects might be more than this medication. So as we get better at creating medications, we get better at making them more and more specific so that we get less and less side effects, which is always the goal.
So, what I'm hearing is that the side effects that were seen in the group taking the Remibrutinib had to do with bleeding. And the big one that we're talking about is petechiae, and that's these little tiny bleedings under the skin. There were other things that Dr. Blaze mentioned, but the petechiae is basically the one that we are going to focus on. And they know that that is a side effect, but remember, the FDA approved this medication, right? So the FDA looked at it and said, is it a big enough concern for us to not have this go on to market? And they said, no, it's okay. So there are these bleeding events that happen, and it's something that you have to know can happen if you go on the drug. And if it does happen, you want to talk to your doctor about that. And together with your doctor, you can decide whether you want to stop it or you can continue. Because another thing that I remember Dr. Blaze saying is that these were transient. So they came and they went, they didn't always stay. So that's again something you want to talk to your doctor about. And the other thing is because they know that these BTK inhibitors can impact the platelets, which is something in your blood. They looked at the numbers of platelets and they saw that they weren't changed in the people who had these petechiae. And that's not something that you have to get monitored when you are on the Remibrutinib.
Thank you, Courtney. I think that was a great summary, and everything that you said is spot on and completely accurate. So again, with all of these medications, as it's out in market, we really start to understand these side effects a bit more and what patients we may have to worry about more than others with these particular bleeding events. But it's a shared decision-making conversation that you definitely will have with your doctor, and they'll explain to you based on your history whether or not there's anything else that we need to worry about before putting you on this medication. The other thing that I want to mention is we don't have to monitor really any blood work while patients are on these medications. So there weren't any issues with liver enzymes, and the liver sometimes is affected by medication. So that's oftentimes something that patients ask about. So there's no issues with the liver. And then as far as infection rate, which is also something that we want to think about with any medication, especially anything that may affect some of our immune cells, there wasn't any difference between the placebo group and the Remibrutinib group. So we're not worried about this increasing your risk of infection. And so all of these things really look positive.
And I can add that blood pressure, heart rhythm on EKG, lab values, all of that was similar between remibrutinib and placebo. And of course, we're always monitoring any study for serious events like death. And again, none were seen in this particular study. So overall, I think the safety profile is reassuring.
So it sounds like remibrutinib was overall well tolerated by patients. You don't have to get your blood monitored when you're taking it. And there is some concern for bleeding events. So if something happens, that's something you want to talk to your doctor about. So, before we conclude, there's one more thing we need to talk about, and that is the limitations of the study that we should keep in mind. And when we talk about limitations, that's really things we need to think about when we're hearing the results and how do we interpret the results, knowing these different items. So, Dr. G, can you tell us about the limitations?
Yes. So there are a few things worth noting. First, this was a 24-week study, so we don't have years of data yet. And we need to see, as I mentioned, how remibrutinib performs over the long term for patients. And does the effect last, for example? And then, as we've talked about for the safety issues, are there any other safety issues that show up later on? So there is an extension study going on that should help answer some of these questions. And what an extension study means is that they're actually continuing to follow the patients that were started on the medication to see how they do beyond that 24 weeks.
And second, this study looked at remibrutinib added to antihistamines. So we don't know from this data how it would work on its own. So without antihistamines in the background, because that's the way the drug was tested. Now, we have, as we mentioned, FDA approval of this agent now, and the FDA did not put in the label that one has to use this medication with antihistamines. So it will be left up to the patient and his or her clinician whether they would continue antihistamines or not if they're placed on remibrutinib. And the third thing I think we have to think about here is this study was mostly white and mostly from Europe. And about 77% of the patients were from European sites. So we'd really like to see more data confirming these results in a really more diverse population.
That's always important. Diversity in clinical studies is really hard to achieve, unfortunately. And so we're working hard to improve that. And I'll just also add that while the results were impressive, we have to remember that not every patient responded. So there were some patients that did not get to that well-controlled disease status that we wanted them to get to. And about half of patients reached the well-controlled disease, which means that half didn't. So this isn't a cure-all for all patients. And so they may need other options or a combination approach.
Great. Thank you so much, Dr. G and Dr. Blaze, for walking us through this study. That was a lot of information. And I think with that, let's get to your takeaways. So, Dr. G, what was your takeaway after reviewing this paper?
Yeah, so I think the biggest takeaway is that we now have another medication for patients with CSU. And I keep saying this over and over in kind of any disease state that we talk about, but more options is always better because every human body is different and we never know which medication one patient may respond to better than the other. And if we only have one treatment option, that means that if a patient fails that treatment option, we have nothing else to offer them. So I'm really excited whenever a new medication comes to market. That just means that I have more tools under my belt to help patients feel better. And again, this treatment option does work in a completely different way. And the BTK inhibitor model is different from what we've used in the past for CSU. So I think that this is really meaningful for our patients with this disease.
Thank you. And Dr. Blaze?
And I agree. And from a practical standpoint, to me, a few things really stand out. One, it's an oral medication. So it's a pill twice a day. And for our patients out there that don't want injections, having a pill is a big deal when the antihistamines are not controlling their hives. Second is that it really does work fast. And we saw improvement from the data as early as week 1. And we know that our patients that are suffering with chronic spontaneous urticaria are really miserable. They don't want to wait weeks to get better from their condition. And then third, I think the safety profile looks favorable so far. petechiae and mucocutaneous bleeding is definitely something that has to be monitored, but it wasn't a major issue in these trials.
Amazing. Thank you so much. It's so exciting to have yet another option for people who are living with chronic spontaneous urticaria. As Dr. G said, it's always nice to have options for people. And as Dr. Blaze said, it's nice that it's a pill and not an injection, so we also have another option there. So with that, thank you so much for listening to another Journal Club episode with us. We always have an infographic in our show notes in case you want to see the results and follow along. And we also will link to the original paper and episodes that we have talking about BTK inhibitors and chronic spontaneous urticaria. So thank you so much for listening, everyone.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.